Yeah. Yeah, Rafael and Yehuda, thank you very much for the invitation. It's a great pleasure to be here as well. It's nice to see so many interested in pediatric neurosurgery. I talked to, I have to start, sorry. Start the presentation better. There we go. Here we go. So I talked to Christian and we agreed that he would concentrate more on the Sella and I will just do the third ventricle. So I don't want to repeat everything again. Now, let me start this here. So most of us or all of us know this picture, right, of the third ventricle. This is very common. We do a third ventriculostomy. This is a beautiful surgery if it's not bleeding. If it's bleeding, then it takes an hour just to wait. But you see the floor of the third ventricle. You see it beautifully through the foramen of Monroy. And then, of course, now the endoscope goes back. And we see also the plexus, and we actually don't see the third ventricle, most of it, because it's hidden by the plexus and the vein. And we'll talk a little bit about how to get there too. Oops. So here we go. So those things are, I mean, the third ventricle, talk about the anatomy of the third ventricle is a little bit like Andrea showed in his slide, one slide about tumors in the third ventricle. It's one slide, two options. One is metastasis, and we hardly see that in children, so there's not much to talk about. But the third ventricle is important. It is the pathway for all the CSF, of course, from the lateral ventricles going down. So in the anterior border, it's very important. We will see from the anatomy, and of course in the posterior border. Inside of it, it's not so very interesting to say that. But again, this is a sketch that we did together with Felix Stengel and me, my resident, to prepare for this lecture. That's always a good chance to go back to anatomy, to discuss anatomy, and to see what is it and learn a lot. And I actually remember when I was a third-year resident, I got four or five hypothalamic gliomas from Bertalanffy, who just operated them, and I was called to present them in a pediatric oncology stage, and I was a third-year resident to explain how hypothalamic gliomas shall be operated, which was kind of funny nowadays when I think about it, but I tried. And so we discussed the anatomy a little bit, and to make it very simple, and that's a little pity because the colors are really bad here and they're much better here on the screen. So we do have the roof, of course, with the fornix, which is very, very important. We'll discuss that for one or two possible cases. But of course, the anterior part with the lamina terminalis, which we see a lot during aneurysm surgery or any other kind of surgery. We'll discuss also some approaches through the lamina terminalis, anterior commissure, the recesses. When we do a third ventriculostomy, we see usually always the infundibular recess, but very rarely you have to really either have a 30-degree angle or you really have to push hard against the fornix to look into the supraoptic recess. On the posterior side also, we see that more often if we take a skid approach, supracellular infratentorial approach, for example, we go through to the pineal region. We have the tegmentum here, which is not the border of the third ventricle, but if a tumor grows up in that region, then the tegmentum gets part of the third ventricle or of this area, of course. We have the lateral borders, which are a little bit boring, the hypothalamus, and the thalamus itself. The roof, again, is the choroid plexus and the fornix. And the internal cellular vein, which play a big part for any approach. And then, of course, we have the very interesting floor. You see, I don't want to repeat all of that. The only one that's interesting is the lamina terminalis. The rest we can't go through, so there's no approach coming from below. So we basically don't have to. The only thing we have to know is don't destroy the floor. It's kind of in the fourth ventricle. Now, much better than me, Roton has a very famous book and publications where they really dissected everything from every corner, and I can just recommend everybody, you see the videos where he explains it in his voice. So I personally am coming from a lot of anatomy courses. I'm a big fan of Roton and his lectures and his dissections from his team. And this is the sagittal view of it. You see it, our sketch was of course nicer than this one, but this is okay. But you see again the recesses, the two. You see the adhesio interthalamica in the middle, the roof of the third ventricle with the plexus and the veins, You see the posterior part again with the pineal region, with the aqueduct, and again, anteriorly, the lamina terminalis, which is kind of like a big door when you look from it. So in the sagittal plane, this is our view, as you saw in the sketch. Now, this is, again, a magnification of it with the anterior part, with the recesses, you see them nicely, and the posterior part. And here again, very important, even if you come from the pineal region, or if you come from behind, all these veins, I don't want to get through them too much, they're all in your way, so that really makes it a tough job at the end, because you have to cross the veins to come into the third ventricle. And when you do that with an endoscope, or if you do that with a microsurgery, they're not just in your way, because when you're operating beyond that, you're always the danger to kind of rupture them or injure them, and that's very, very dangerous. So we do that approach, but we all know that it is not one of the easiest ones. Now, the axial plane, if you look at the picture, and even I have to get used to it a little bit, where am I and what's going on? But most important, when you come from above, and if you basically was able to dissect all the brain away and callosum away, this is what you would see with the veins, of course, the intracerebral veins, the plexus choroideus, and when you take them away or off, then you are in the whole length of the third ventricle. Now, this approach, I have never used it to split the fornix. I don't know, maybe somebody has done it in old days. I don't think anybody would do it. But of course, nowadays, you would choose a transchoroidal approach. You will go from laterally, open the ventricle, and then go all the way down. This is the view that you would have from laterally, foramen Monroy, the vein, and then if you open the transchoroidal approach, you will be completely in the third ventricle. Now, this is in an anatomy lab. In real life, it's much different. It's not so big. You don't have this light. You don't see anything. So it's much more difficult than you see here. But again, you see from above the infundibuli. As you see here, you see the mammillary body is the floor of the fourth ventricle, where we like to puncture and do our third ventriculostomy. And below is the basilar artery. And this is one more picture from the Roten series where they go through this. Hello? Yeah, go through it. So once you open the third ventricle and once you have the EVT all the way down, of course, not just the small hole that I showed you, but all the way down, you see, of course, the basilar artery, the third cranial nerve going through. And this view from above, you would only have if a giant tumor opens the whole space for you. And then when you take the tumor out, then you will see a picture like this. But in a normal anatomy, you would never get this exposure. You would have had destroyed too much to get to this point. But this is the way from above. Now, the coronal view is very interesting, as you see from the right picture, because once you go through the lamina terminalis, you look all the way through the aqueduct. So it's kind of appealing. Especially Japanese colleagues love this a lot, but it needs a giant craniotomy, subfrontal approach, dissection of the both hemispheres, which is not so easy on children. They're very stuck, to be honest, and you make a lot of small injuries. So I don't really like, I tried it, but I don't really like it too much. But once you are through to the third ventricle, through the lamina terminalis, your view is really all the way to the aqueduct, which is kind of nice. And you don't have major veins in your vein that you could injure, etc., etc. So it's a big approach, giant incision, but then at the end, your view coronal all the way through is not too bad. So it really depends on the lesion which you want to target. And that, again, is also not a new concept. It's not my personal concept. It's a total logical concept. Once you have a lesion in the third ventricle, you first think about what is it and how do you, where is it exactly in the third ventricle, of course. Then you think about the anatomy. What is in my way? What vessels do I have to check first before I go in? And then again, as I showed initially, you have to incise something. So you can't just get to the third ventricle without incising anything. So either you have to incise the choroid plexus next to the fornix, or you have to incise the lamina terminalis, or you have to come from behind. But the third ventricle is closed. It's not an open space. So you have to make this decision. And then again, once you have that, as you can see here, you have to come through somewhere. And that basically chooses your approach, whether you're subfrontal, as I showed you from the mostly Japanese groups that advocate that. Again, I did that a couple times. I'm a very big a friend of the posterior approach for the third ventricle. But then again, also the transcallosal, transchoroidal approach is very appealing. You just need a lot of good light. That's the biggest problem. coming again from the transsphenoidal part. I will not talk too much about it, but you will see today. And I think, Raphael, I think you will talk about endoscopic transventricular approach. So we'll hear about that too. Now I want to show you, just to warm things up, because there was a lot of anatomy coming into cases and make it a little bit more interesting. So this is a case that was the place where I'm now in St. Gallen. It was presented before me, before I came there. And this is a 14-year-old boy with this lesion, most likely pilocytic astrocytoma. And he had a hydrocephalus, as you can see here. Unfortunately, I don't know why they didn't do an EVT. They put in a shunt, which was still okay. The shunt was working. But 2 years later, and nobody knows why there was no imaging, but 2 years later, the whole third ventricle is full of a tumor. So now you can, the good thing about that is you can decide your approach. You can choose anything, right? So you can come from the front, you can come from the back, you can come from above. All is yours. Shlomo, what would have you chosen? Since it's initially from the back, that helps.
Just to mention that now we have not only this, we have also another front of biological treatment. Get a biopsy and try the biological responses. I've seen some remarkable responses. I'm missing the sagittal view, but I would assume that they would do this pre-coronal from above, interhemispheric, because it goes too much anterior to go from the back, right? And both from the supracerebellar, from the occipital, and the interhemispheric parietal, which you do for peneals, it goes all the way to the front. So I would just go, pre-coronal interhemispheric.
Yeah, and I think this picture helps a lot, because you can see your sagittal is here. It comes really behind from the tectum. The tectum is lifted up. And that's why I'm saying now the tectum is all of a sudden a part of the third ventricle. And if you come from the back, it sounds like appealing. You are really close to the tumor, but you will destroy the tectum, first of all. And secondly, you don't look. It's better to take first the tumor out and have the look on the surface at the end of your surgery, not in the beginning of your. It's not a meningioma which you have to cut and take the blood supply away. It's basically the other way around. Take first the easy tumor, and then at the end you have space. So yeah, we did the same thing. We took the transcallosal approach. This is the sagittal view now. We took everything out, but the non-enhancing part on the tegmentum, we did this intentionally because, as you said, there are some biological ways now to treat this patient, and this patient had no double vision at all. So we stopped right at the point before getting into trouble. And that was the most important. So to give some time for the therapy and to view, and it was a pilocytic astrocytoma. But I think too, yes, the transcallosal. But again, for transchoroidal approach, the light is a problem, And Spätzle invented this suction light, which is great, but it costs about 2,000 per case because it's a one-time thing used. And you have to buy this machine that, of course, costs a lot more. And then you need it for 3 cases a year. And then, this becomes very expensive. But yeah, so we made this choice. Now to spice things up a little bit more, it's a very sad story, actually. This is I don't actually know. I think it's a 6 or 7 year old, 2013, no, 9-year-old girl we saw 6 months ago. And you see neurofibromatosis, both septic nerves dilated, and she has a fornix lesion. You see actually here in the diffusion, it's the best picture. You see that the fornix are going apart. So it's the roof of the third ventricle. It's not really a third ventricle tumor, but it's the roof of the third ventricle tumor. And in that case, I don't know why. I don't like prophylactic surgery. I hate prophylactic surgery. We put in 2 shunts. We put in a shunt on this girl because we were a little bit afraid that eventually she will get into severe trouble. We put in a shunt and we biopsied this just to have all the genetic profile. And we said, girl is doing fine, very fine actually. Procedure went super. She went home and we said, let's do an MRI 6 months later, which is now. And where is it? These days she came back. I don't know why it's not functioning, sorry. Yeah. In 6 months. And it was a normal pilocytic astrocytoma. In 6 months.
Incredible. And she's a net.
Yeah. In 6 months. So I'm actually happy that we did put in the shunt, because she would have decompensated probably on the way somewhere at home. But I would have never expected that. I was really more for long term. not for no EVT. So now we have to deal with this tumor, and yeah, I'm looking forward to this symposium today.
The tumor got angry because you touched it.
You think so?
Right. There's this concept, right? Don't make the tumor angry. You know? It's an old concept.
I have to admit it was growing before too, but it was not growing as fast. So that's why we started, because they knew she had this tumor, they controlled her, and it was growing, and the forearm and Monroe were closing, and that's why we said before she gets into trouble, we'll put in the shunt, and now it got really fast, you know. But yeah, but we didn't spread it. We didn't with the needle. We don't see any tumor up here. So.
Just irritated.
Okay, so we'll have that, and then the last case just for fun. No results here, just to open the next lecture. I don't know why this is not functioning, sorry. I'll do this here. Yeah, so I knew you would see a lot of anterior third ventricular tumors today, so I chose to choose the posterior third ventricular tumor. So this is basically the question to the next speaker, radiological science for these tumors. I'll tell you, and I will reveal the truth not now, but later, but I can tell you it's not a germ cell tumor, and it's not a pinealoblastoma. So now it gets really interesting. All right, but that's pediatric neurosurgery. I always say they're always case reports, you know, all of them are case reports. So that's it, thank you very much.